So I'm going to be presenting the details of access for retrograde SFA, popliteal, and intra-stent access. I think if you were at the live case session this morning, we saw an excellent example by Dr. Schmidt regarding retrograde SFA access, and he humored us by taking a few minutes to get in the artery. So retrograde access has some significant advantages via the SFA. The first is that you can treat the patient pretty easily in the supine position. There's not a need to turn them prone the way you often do with popliteal access. In fact, it eliminates the need for popliteal access in carefully selected cases, and I think also does have the advantage of being able to use larger sheath sizes to deliver equipment. For that reason, this becomes, I think, in many cases of ostial or proximal SFA occlusion, a preferred access point as compared to doing a high anterior tibial or tibiopedal access. There are, of course, some disadvantages. One of these disadvantages is that this is a relatively non-compressible site, and the second is that it can be challenging to access the distal SFA in obese patients because the length that you have to advance the needle can be fairly extreme. So here's the description of the technique. This, if you want to reference this, there's a really great article from Journal of Endovascular Therapy in 2012 that describes this in 50 patients and also goes through the details of the technique. So you have the patient in the supine position, and the goal is to access the site of the distal SFA medial in the medial and ventral thigh, distal to the adductor canal. I'll show you what that looks like fluoroscopically in a minute. And in general, you can use a 21 gauge needle. You want to match it in general to the size of the thigh that you're using. And one technique that you can use in order to get better purchase with the needle is to actually place a long micropuncture needle inside of a shorter 18 gauge Cook needle in order to provide better stability through the muscle puncture. Because oftentimes with retrograde SFA access, the distance that you're puncturing may be in the range of 4 to 6 inches, and you need to have enough wire support in order to be able to access the artery. So here's some example of the technique. You start off by getting a contralateral oblique about 30 to 45 degrees to line up with the artery. So for example, if you're accessing the distal right SFA, you would go in the LAO position. And then you rotate to the contralateral oblique from a prior view to assess the needle distance from the vessel. So you start off contralateral, that lines up the artery, and then you start heading in. And then you go in the other view, which then demonstrates the steepness with which you are approaching the vessel and whether you're deep enough. And I think one key to doing this access successfully, as was mentioned this morning, is you want to have an angle that's not too steep, because if you are aiming straight down into the vessel, it can sometimes be difficult to advance the subsequent wire and or dilators. With regards to hemostasis, there are two ways to do this. One is assuming that you were successful with the eventual procedure to perform intraluminal balloon occlusion, and this can be done for about 5 to 10 minutes. People have also reported using external compression, using a blood pressure cuff inflated to suprasystolic pressures, generally 20 to 30 millimeters of mercury above what the arm pressure is, and to do that for about 10 to 15 minutes in order to achieve hemostasis. So here's an example of this technique. This is a 73-year-old man with breast pain. He had a left ABI of 0.32. He had a known heavily calcified left common femoral and an occluded SFA. He actually had been referred to surgery, and there had been a plan initially for a common femoral endarterectomy and fem-pop bypass, but intraoperatively it was decided first off that the patient's veins were too small for an adequate bypass, and during the endarterectomy there was significant bleeding at the origin of the SFA such that an emergency ligation was performed of the SFA. Unfortunately, the patient's rest pain persisted, and he was referred for further evaluation and second opinion. So you can see in this case the common femoral does have the appearance of the endarterectomy. Unfortunately, there's significant residual stenosis at the origin of the profunda, and you can see here that the origin of the SFA had been ligated. Coming further down, you can see that there was reconstitution of the SFA in the mid to distal SFA just above the popliteal, and actually fairly good runoff otherwise. So in these cases, the ideal access point is generally to have some reconstitution of the vessel slightly above the level of the femur here in the distal SFA. You can see that our access here is just above the adductor canal. And in this particular case, I used a Cook needle and went straight in with a supercore wire as opposed to using a micropuncture technique. I think that this is a decision you want to make based on the patient and the depth with which you need to perform the puncture as well, regarding the amount of wire support you may need in order to advance the sheath. And in this case, I was a little bit too steep of an angle. You can see that I'm a little bit too straight down on the vessel. Ideally, you would have your needle at more of an angle like this, so it performs more of about a 60-degree entry point. However, this was sufficient to advance a sheath. I placed in initially a 4 French sheath, but then had to use the back end of a straight stiff glide wire to get up next to the SFA in the common femoral, and then upsized to a 6 French sheath in order to be able to advance a Pioneer, which then I then used to perform re-entry into the common femoral. This is all via the retrograde SFA access. Then I externalized the wire through this quick cross capture balloon. And then interestingly, this is the site of the ligation of the SFA, and this is a balloon at 40 atmospheres demonstrating that there was a significant residual waste that would not pop. So I did eventually advance a cutting balloon, actually, and inflated the cutting balloon, which I think snipped the residual suture. And then everything was pretty easy from there, allowing subsequent balloon angioplasty, placement of overlapping nitinol stents, and this was the final result. So I think this is an example where retrograde SFA access really can make a lot of sense. I find this an extremely useful access technique for ostial SFA occlusions where there's reconstitution at the proximal popliteal. So with regards to popliteal access, the advantage of this is that it does allow access lower in the leg than with the retrograde SFA access. It's also, I think, somewhat easier to access in obese patients. The disadvantage is that in general it's usually been described and utilized as a prone positioning. However, it is possible to frog leg patients in order to access the popliteal. In my opinion, I think that it's relatively difficult to image the popliteal when you're gaining access, and I think that there is greater potential for vascular injury. If you start imaging a lot of popliteals, you can run into situations where the popliteal vein is directly on top of or right next to the popliteal artery. So I think the potential for vascular injury does remain higher and the potential for subsequent bleeding. This is an example of retrograde popliteal access, courtesy of Dr. Banerjee. This is a patient who had an ostial SFA occlusion as well. The reconstitution was relatively low in the leg, and the patient was placed prone in this case. And then you can see in this case, an outback catheter was used in order to line up the ostium of the SFA right near the common femoral and perform re-entry in order to be able to get up and reconstitute the whole SFA. The final aspect of the technique I wanted to discuss is retrograde stent access. And this is similar, basically identical in many ways to retrograde SFA or popliteal access. However, in many respects, it's actually easier to perform because the stent struts are acting as a landmark. I would caution that you want to take some care with dilation of the struts, but it is actually relatively easy to access nitinol stent in the distal SFA. This is a patient who has a proximal SFA occlusion here. You can see there's a short stump. Interestingly, he had a prior nitinol stents that had been placed in the mid to distal SFA, and there was reconstitution of the SFA within the stented region. So this was actually not an in-stent occlusion, but instead a more proximal occlusion. This doesn't look like it's a particularly hard case to do, but for one reason or another, I think the stents had been underexpanded proximally, and when I went down with initial wire, got stuck behind the stent tines and got stuck in a situation where I could not access the true lumen of the stent. So therefore, decided to perform retrograde SFA access. This is a fluorosave capture showing, in this case, you can see I used a Cook needle here and then a longer micropuncture needle through that. So you can see it's kind of a double needle technique. And on this capture, you can see that I actually had the needle in a little bit far, brought it back, and then re-advanced the wire, and you can see the micropuncture wire going up very nicely through those stent struts. I then advanced a micropuncture sheath through the stent struts, which went very easily, externalized the wire, turned around, completed the case, and got an excellent overall angiographic result here. And then in this case, I did inflate a 6mm balloon for about 10 minutes in the distal SFA at that access site. Thought it was also prudent to redilate whichever struts I had disrupted while getting the access. So this is a nice alternative technique for some of these complex cases. So in conclusion, retrograde SFA and popliteal access, I think, really do help expand the treatment options for patients with complex superficial femoral artery disease. I think there's been a lot of focus on tibiopedal and extreme access, but the reality is if you look at a lot of literature, even for complex SFAs, there does remain a certain failure rate of procedural success. And I think if you start adding retrograde SFA and popliteal access to your toolbox, the success rates for even the most complex SFA occlusions are nearing 100%. One of the big advantages, of course, is it does allow greater pushability than with tibiopedal access, and you can potentially upsize the sheath in order to perform re-entry as well. And so I think in general, I would consider this an ideal technique for proximal osteal SFA occlusion with distal reconstitution. Thank you.
Thank you.